Is this the room for the ED training?
Oh, it is. Come on in.
Okay. Do you know how long this is gonna last? I just got off at 12, so I'm kind of tired.
Just give me about 10 minutes. 10 minutes of your time and I'll be able to explain everything. All right, good morning, everyone.
Good morning.
Thank you for joining us at one of our many mandatory workshops on policies and procedures in the emergency department. As registered nurses working under a healthcare facility, it is imperative that we each understand and follow the policies and procedures in order to ensure safe practice and patient care. So today we will be focusing on one issue that has come up several times on our unit, which is the frequency of vital sign assessments. So we have recently changed our policy based upon the reflection that has not been efficient for our facility. So before we get started, do you guys have any questions?
Is there snacks?
There are not snacks.
I do. How often are we supposed to assess vital signs? Because I'm a new grad here, and I always hear different things.
Yeah, of course. Excellent question. That will be answered during the presentation. Okay, everyone, now that everyone's got their pens, their pencils, and their paper, we're going to go over the policies and procedures. So basically standards and guidelines that are implemented for healthcare institutions, are the policies and procedures. Yes.
Do we have this printout, or is it posted in the unit?
Yeah, this is actually posted on a couple of the walls on the unit, so I'll be handing these out. Oh, you haven't seen them? All right, well, after the presentation, we can go and find them. The objectives for today will be to implement evidence-based practice into patient care, ensure quality of care, and improve patient outcomes. So we will be addressing the policy, and what will be addressed is the frequency of vital sign assessment, as the question that you asked earlier, and what that will be in the emergency department. Who will be addressing? We hope to be just teaching our unit staff members, all of our registered nurses, so that we can relay this message to the EMTs on the field and anyone else that we come in contact with. So the old policy was that the vital sign assessment in the ER would be done at a minimum of every 2 hours and with increased frequency depending on patient acuity. This increased frequency can also be done with medication administration and as far as just your overall clinical judgment as a registered nurse. So the new policy that we're going to be implementing and that I'm hoping to be teaching you guys on is going to be a little bit more specific than the vital sign assessment that we previously had in the ER. This one will be done at a minimum of every 2 hours for all patients, and we're going to be implementing the ESI, which is Emergency Severity Index, and that will go based on a number scale of 3, 4, or 5, with patients having an ESI of 2 or 1 requiring vital signs to be done every hour instead of 2 hours. And then with even more increased frequency depending on the severity of ESI of 2 or 1, medication administration and or your clinical judgment as a registered nurse. So does anyone need a handout on this ESI? Everyone? Okay.
This sounds like it's gonna be fun. Right. Something else to do.
Now, I know that seems like a little bit more, but as nurses, we want to make sure that we're implementing evidence-based practice so that we can give the best care to our patients. So now that everyone has a handout, I'm going to just familiarize you guys with the algorithm that's going to be helping you determine the ESI. So if you look to our handout, the triage algorithm, volume 4, so if your patient requires immediate life-saving intervention, you're going to immediately ask yourself yes or no. If yes, we skip all the way to box, we're going to immediately grant them ESI of 1. If you answer the question no for requiring immediate life-saving intervention, we go ahead and go to box B. So is this a high-risk situation? Or is the patient confused, lethargic, disoriented, or as far as pain, is their pain severe or are they in distress from their pain? Now if you answer yes, that's going to be an ESI of 2. Now if you answer no to any of those questions above, we're going to skip down to box number 3. Now box number 3 is how many different resources are needed? None, one, or many? If it's none, ESI of 5. If it's just one resource, ESI of 4. And if there's many resources that we need, we don't know how many, that's when we're going to be going to box D, which is going to show us the danger zone vitals. This guide of the danger zone vitals will be your guideline to being able to help with your clinical judgment and making a decision on whether to grant this patient an ESI of 3. But based on the severity of the vitals, we can actually jump down from an ESI of 3 and upgrade the patient to an ESI of 2. So this is all going to be based on your clinical judgment as a nurse. So hopefully that we can work with future trainings on how to be better at making that judgment. For example, ROSC achieved cardiac arrest patient would be an ESI of level 1 because it requires immediate life-saving intervention. This patient with severe hypotension being administered Levophed, which is we're going to do vital signs every 5 minutes post Levophed administration, and 15 minutes minimum times 4, so in 1 hour, or until the blood pressure is consistently stable, and Q 30 minutes continuously once the BP stabilizes. So any titration of the Levophed requires 5 minutes post titration and restart of the vital sign assessment cycle. So vital sign assessment frequency will be different if the patient had a lower ESI level. So any confusion so far? No? Perfect. So basically what we're going to do now is we're going to practice with some brief scenarios that have been developed. But I want to, instead of going off of what's been developed, I kind of want to hear from you guys. Do you guys have any stories that you've seen, any scenarios that you've gone through in your previous time here? Yeah, Kavana.
Okay, well, I had a guy come in last night from a run. He came in with a GCS of 9. He has a history of dementia. He was hypertensive, chronic kidney disease. His blood pressure was like 116 over 69. Respiratory rate 22. He had a fever like 101. And he came in with a catheter and then amber, foul smelling urine.
Okay, so, I mean, excellent scenario. Now, going off our algorithm, what do you think that you would designate this patient?
I think it would be a 1 because he was a GCS of 9. But
I don't know. I would say, well, he needs many resources, so maybe a 3.
I know. See, that's where it gets kind of confusing because we had to do both.
You guys bring up a good point. It would be probably between 1 or 3, so you probably end up with 2, since
In between both.
probably.
Yes.
I mean, 9 isn't that low, so we can probably just go in
He was
between and
just
use that
out
many
of it.
resources.
Perfect. I love the discussion. So, and that's what we want. With this algorithm, we're going to be using our clinical judgment to try and work through this problem. So with this scenario, we have a patient that came in with an increased altered level of consciousness. Now, if you look at your algorithm, does a person with increased altered level of consciousness require immediate life-saving intervention? Maybe, but not this patient, not based on their vital signs. So we're going to say no, and we're going to skip ahead to box 2. Now, is this a high-risk situation? It could be with an altered level of consciousness. Is patient confused, lethargic, or disoriented? This patient definitely is. So, based on that, we're going to answer yes, and we're going to make that an ESI of 2. Based on this patient, it sounds to me like this patient is going through possible sepsis. So, everything that you guys did, every test that you guys ordered, perfect. So, vital signs assessment and documentation, how did you go about that?
Well, with my preceptor, I've been following the old policy, and with that one, we just do them every 2 hours.
Correct.
And so I remember his temperature was getting better, it was going down, but the rest of his vitals were getting worse. Like his heart rate kept going up and his blood pressure kept going down.
So,
So when
patient
we
was
went back-
compensating.
Yeah, when we went back like for the 2-hour mark, it was just getting worse.
Okay.
So
Okay.
I guess it kind of makes sense because if we would have followed the new way, we could have caught it sooner.
Yeah.
Exactly, exactly, and that's what we want. We want to be able to catch these things sooner. We want to be able to, you know, assign an ESI for the patient severity so that we can have guidelines in order to follow that and catch these things sooner. So I do want you guys to take a look at box D again for the danger zone vitals. So this can be implemented for an ESI of 2 or a possible 3. So based on these danger vitals. So with the sepsis patient, you know, they are going to have dangerous vitals. So once again, we're going to be implementing that. As far as that scenario, great work today, everyone. I'm glad that you guys came in. I know it's just a little bit more time, but once again, like I said, we want to be following evidence-based practice, and we want to be giving the best patient care that we possibly can. So after going over this algorithm, are there any last questions or comments that we would like to, you know, kind of go over or reflect on before we leave? Yeah, Cabana.
I don't know about improve, but you know, as a new grad, it'll be easy for me to just start doing this.
Mhm.
But I just wonder about some of the nurses that have been here longer. Will we have a hard time with them, or maybe bring them into the training too, so we can just show that everybody's doing this and they don't just think we're doing it differently?
Of course, of course. So did you guys feel like you learned a lot today?
Yeah, I'm actually glad I
today.
stayed.
We learned a lot.
Yeah.
Perfect, perfect. Any suggestions other than snacks?
Maybe post this around the unit.
Okay, perfect, yeah.
I probably don't remember.
Yeah, no worries, of course. Everyone, thank you for your positive feedback. We hope that this policy change will improve our patient care. And please continue to come to these events and please continue to provide positive and constructive feedback on this new policy once we know we implement it and you guys are able to use it.